Hey, future respiratory therapist, I got a video here for you today. Comes from a viewer named Tay who wants to talk about aerosol versus humidity and specific questions about things like the vibrating mesh, the ultrasonic neb, the wick, HMEs, humidifiers, things like that. So we're going to break this down for you. I'm really excited about this because a lot of the questions that I receive are revolving around mechanical ventilation, because that's typically the more challenging part of respiratory therapy school and respiratory therapy education. But when we get to the state of start talking about mechanical ventilation, what we often do is forget about these topics that we learned prior to mechanical ventilation. So I'm really glad Tay sent me this question. She wants to, just maybe review this stuff, or maybe even if Tay's a first semester or a second semester student, maybe just sharpen up her skills on understanding the differences between these devices. When would you use one versus another? So that's what we're going to break down here today. Now, you can see here on the board we have aerosol versus humidity. And on the surface level, if you're ever in a room and you're asking yourself, is this aerosol or is this humidity? The easiest way to break this down is ask yourself, can I see it? Can I see the aerosol? Or can I see the delivery to the patient, or can I not? If you can't see it with a bubble humidifier or a passover humidifier on a mechanical ventilation, you can't see that. You can't see that moisture being put into a state of aerosol or in a state of humidity, then it's humidity. If you can see it, if you see the mist coming out of the trach collar, of the face tent, of the small volume nebulizer, then we're talking about aerosol. So that's on the surface level. That's how you can tell real quick what it is. Now, some of the newer aerosol devices, it's really hard to see the mist, but just take it, put it against a dark surface, maybe put it in the light. If you can see the aerosol, then that's what you're dealing with. You're dealing with an aerosol device, not a humidifier or a humidity-based device. Okay, so that's the first thing. The second thing you want to understand is that aerosol has larger particles than humidity. Now, the fact that it has larger particles makes aerosol more likely to be associated with cross-contamination or infection due to the equipment that you're using. Okay, so those are the two big things right off the surface that you need to clarify. Understanding that aerosol is visible. Why is it visible? Because it has larger particle sizes, and that makes it more susceptible to associated infections and cross-contamination. So we're going to start there. Now from here we're going to break it down. So I'm going to draw a line on the board right here. We're going to keep this side for humidity, and we're going to start with aerosol. Now when you talk about aerosol devices, you got to talk about a few of the basics. And what this breaks down to is medication delivery versus bland aerosol. Okay? So you got to understand that we use aerosol devices, one, to deliver medication, and two, to deliver bland aerosol to our airways. And we're going to talk about the differences in what these look like. Now, when we talk about medication, the first one we have to talk about is a meter-dosed inhaler. So this is where you have a canister full of medication that when you depress it, it turns it into an aerosol. We can see this, right? So we understand that this is now an aerosol device. Now, the thing that you need to understand about MDI is not so much related to MDI, but it's MDI versus DPI. Now, DPI is not an aerosol device. It's also not a humidifier. A DPI is a dry powder inhaler that's associated with delivering drugs to the airways based off of a dry powder. So the medication is not aerosolized. So why am I bringing this up? Well, the reason being is because when you talk about MDI versus DPI as a respiratory therapist, you have got to understand, how do I instruct my patient to do these devices and how are they different? Okay, here it goes. You ready? Write this down if you're taking notes. In MDI, you want the patient to breathe slow and deep with an inspiratory hold at the end. Slow and deep will maximize deposition in the airways, which is what you're trying to get the medication to. Now, when you give a DPI, the function of a DPI and the way they work is they're based off of an inspiratory flow. So your patient has to breathe in deep and fast. When they breathe in fast, they will draw the medication out of the device and into their airways. Breath hold at the end maximizes deposition. So the difference is MDI is deep and slow. DPI is deep and fast. You got to start there when you're talking about aerosol devices. If I didn't put MDIs in here, I'd be doing you a disservice. Okay, so understand those two differences between those devices right there. Okay, and of course, always if you're delivering a corticosteroid, whether it's MDI or DPI, always have your patient rinse their mouth, right? Now, the next thing we go to is SVN. This is a small volume nebulizer. Now, a small volume nebulizer operates off of a flow of gas coming through the nebulizer. It uses a baffle. So as the gas passes through the medication, it aerosolizes that medication, and then a baffle breaks it up into small particles. The patient then inhales those small particles, and that drug hopefully reaches the airways that it's designed to reach. Okay, so this is the most common device that we use when we talk about delivering, let's say Q4-hour albuterol or Q6-hour Duoneb, or any of our aqueous solutions that we deliver to our patients who are spontaneously breathing, not on a ventilator. We usually do this through a mouthpiece or a mask, okay? Now, what you want to remind your patients to do when you're delivering an SVN, just like with an MDI, is to occasionally do a deep breath with a breath hold. Again, this maximizes deposition in the airways that we want it to be, okay? So that's a small volume nebulizer. If you're ever wanting to deliver, if you're ever asked the question of how would you deliver 2.5 milligrams of albuterol aqueous solution to your patient, the answer is probably going to be small volume nebulizer. Now, what if that small volume nebulizer and that one treatment does not fix your patient? What if it doesn't do the job for your patient? Okay, let's say you have a status asthmaticus that comes in, and one albuterol treatment is not the answer for this patient. Then you have to give multiple treatments to this patient, right? So a lot of times we'll do this maybe through 2 or 3 back-to-back SVNs. But the other option is to give this through a large volume nebulizer. Now, when I say large volume nebulizer, I want you to understand that a lot of times when we talk about large volume nebulizers, we can use those to deliver bland aerosol. So you're going to see large volume nebulizer come back in down here in bland aerosol also. But there's also a couple of devices that if you were wanting to give a continuous treatment to your patient, let's say 10 milligrams of albuterol, okay? Then you would use a large volume nebulizer to do so. It works essentially the same way. A flow of gas goes through the nebulizer, through the medication, aerosolizes it. There's a baffle that breaks up the particles into smaller particles. The patient inhales, occasional deep breath. The difference is we're putting 10 milligrams of albuterol into the large volume nebulizer as opposed to 2.5 milligrams. So if you think about this, when we say 10 milligrams of albuterol, we're talking about 4 unit doses. Well, you know that you can't fit 4 unit doses of albuterol into a small volume nebulizer. So you're going to have to use these larger nebulizers. Now, there's a few of these on the market that are specific to delivering continuous albuterol and other continuous aerosolized treatments. Those are the HEART, the HOPE, and the Spag. Now, I put Spag on here, even though the Spag is severely outdated. The Spag takes us back to 1940s. Okay, so this is when the Spag was originally developed. Spag stands for Small Particle Aerosol Generator. And Spag was specifically related to ribavirin for the treatment of RSV. Okay, now lots of problems happened with continuous delivery of RSV, healthcare worker complications and hazards of exposure. And also, the drug is very sticky, so it impairs the valves associated with the Spag, and also if you're delivering this through a ventilator, then you have to watch the stickiness of your expiratory valve while on mechanical ventilation. That's the Spag. It's old. Just remember, Spag goes with ribavirin and RSV, and you'll be good. Now, you don't really typically see that anymore, okay? So for us in the ERs that we're working in today, if you need to give a continuous medication greater than 1 or 2 treatments, you're probably going to use either the Heart or the Hope. The importance here is understanding that those are large volume nebulizers to aerosolize medication over an extended period of time. Okay, so that's kind of where we go here. Don't think SVN in Heart. Now, when I say Heart, I'm talking about the brand name of the nebulizer. When I say Hope, I'm talking about the brand name of the nebulizer. So if you're taking your board exams or you're taking a test and it says, hey, you wish to continually nebulize 10 milligrams of albuterol, which device would be best suited to do so? MDI, SVN, Heart nebulizer, or Spag, then you're going to go with the Heart nebulizer. Okay, so that's kind of where that goes there. You could substitute Hope in for Heart. Okay, those are designed to deliver medications over an extended period of time beyond just back-to-back therapies. Okay, so that's the LVN there, or the large volume nebulizer. Now from there, we have the ultrasonic nebulizer. The ultrasonic nebulizer works off of a principle not of a flow of gas. This is typically powered by either batteries or electrical source. And what the ultrasonic nebulizer does is it maximizes output of aerosol particles. So the output is much greater than that of an SVN and an LVN. The particle sizes are typically much smaller, and the output is much greater. Now here's what you need to know about the ultrasonic nebulizer. The output of the medication is directly proportional to the amplitude. So if a question asks you, how would you increase the output of an ultrasonic nebulizer, the answer is increase the amplitude. If the question asks you, how would you decrease the particle size of an ultrasonic nebulizer, then the answer will be to increase the frequency. You see, ultrasonic nebulizers work off of amplitude and frequency. Output, total output, when we're talking about aerosol output from the device, is directly proportional to the amplitude. Particle size is inversely proportional to the frequency. So if you want larger particles, you turn down the frequency. If you want smaller particles, you turn up the frequency. Now, most of these devices on the user end don't have the ability to adjust frequency. So this would just be a question-based scenario, okay? They do give you the ability to manually adjust the amplitude, which will adjust, as we've already mentioned, the output of the aerosol, okay? Now, I'm running out of room here, so I'm going to come over here, and I'm just going to say we have the Vibrating Mesh nebulizer. Now, when we say Vibrating Mesh, we're talking about the most popular one that I've seen used to date is the Aerogens. Okay, so if you're using the Aerogen nebulizer, what you need to know is that you're working with a vibrating mesh. Okay, now this also puts out small particles at high output levels. But the key to the vibrating mesh and the key to the Aerogen is that when you use this device in conjunction with mechanical ventilation, this device does not add flow to your circuitry. When you give, let's say you're giving Q4 albuterol to a patient on a mechanical ventilator. If you're using an SVN, then what you're going to see is during that treatment, you're going to see your tidal volumes go up and your minute ventilation go up. And if the patient is in CPAP, the added flow to the circuitry associated with the SVN might even mask the patient's ability to trigger a flow-triggered breath because of the added flow. See, the vent, as smart as these vents are, and if you've watched this channel for any time, then you know exactly what I'm about to say. As smart as these ventilators are, they're also very stupid. When you take something that the vent is not in control of and you put an SVN or a small volume nebulizer in line on a ventilator, then you're adding flow to the circuit. The vent does not understand where this where this extra flow is coming from. So it reads out off of its flow sensor that there's a greater tidal volume being delivered and there's a greater minute ventilation delivered. So if you do your ventilator assessment and you start your treatment and then you do your vent assessment, you're going to be documenting wrong numbers. Your minute ventilation, if it was prior to the treatment, if it was 9 liters per minute, and then you put your SVN into the circuit, and suddenly your minute ventilation is 15 liters per minute, that's because of that SVN you added. That extra flow is being calculated as volume coming back from the patient, even though it's really not. And so you're going to be documenting false numbers. Don't document 15 liters per minute when the patient's true minute ventilation is 9 liters per minute. Okay, so you want to be aware of that. The vibrating mesh nebulizers, the Aerogens, they do not add flow to the circuit. And so you can start your treatment and then do your vent assessment and understand if you're working from a time management perspective and you were told start your treatment and then do your assessment, then that's fine. Now, I always preach do your assessment first and then give your treatment. Because see, if you do your assessment first, then give your treatment and then follow with a post-assessment, then you can actually see if that treatment actually helped your patient or not. I ask this question to my students all the time. I say, you gave an albuterol treatment. What were the effects on the peak airway pressure before and after the treatment? And if they can't answer it, I say, how come you can't answer that? You should understand that you're giving a bronchodilator. You're taking your time as a respiratory therapist to deliver a bronchodilator. Now, if that bronchodilator is effective, meaning bronchodilation happens, then your peak inspiratory pressures in volume control should decrease. And if they don't, then you need to ask yourself, is this treatment even indicated? Is it doing anything for my patient? Do I even need to be spending my time giving this treatment? Because perhaps you don't. Okay? So that's kind of where I go with that. These are the medication devices associated with aerosol therapy. There's more. We could break SVN therapy down to continuous aerosolization, breath-actuated aerosolization. A lot of different breakdowns. But for the general macro of things, this is a good starting breakdown of medication delivery aerosol devices and how we give them and when we should give them. Okay, now from there we have to talk about aerosol. We have to break it down to bland aerosol delivery. This is when we're not giving a medication, but we wish to deliver aerosol to our patient. Okay, this is when we're talking about trach collars, face tents, aerosol mask, things such as that. Okay, the patient has thick secretions and we want to give some aerosol to help mobilize and move those secretions. So we will give a bland aerosol. Now, when it comes to bland aerosol, what you typically need to know, and again, I could go deeper into this, but I'm just going to keep it surface level. We're talking about bland aerosol. The question is, do we deliver cool mist or do we need to warm it or provide heated aerosol? So when I say warm, I'm saying heated aerosol. When I say cool, I'm saying a large volume nebulizer set up without any heater device attached. The answer to this question is anytime you're bypassing the upper airway. Okay, remember the upper airway is what warms and humidifies our gas naturally. So we inhale, we take in dry, cool gas. As it passes through our nose and our upper airway, that warms it. And then we exhale. What do we exhale? We exhale warm, moist gas that gets trapped in our upper airway and in our nasopharynx. And then the next breath, as we pull in cold, dry gas, comes back through and that heat is picked up. Now, when you bypass an upper airway via tracheostomy or an endotracheal tube, that natural heating and humidifying system is bypassed. And so with those patients, we need to provide heated aerosol for. So this is a trach patient. I'm just going to put trach or endotracheal tube. That's when we provide heated aerosol for our patients. Now, when we provide cool mist aerosol for our patient. This is in cases of upper airway edema, which will show up as stridor. So if your patient has stridor, which is evidence of upper airway edema, then you want to vasoconstrict those vessels in that region. You'll do that by depositing large aerosol particles, cool aerosol particles, in those regions, and that will cause those vessels to vasoconstrict and hopefully reduce the edema associated with your patient. Okay, so we talk about bland aerosol. Always ask yourself, cool or heated? Bypassed upper airway, go heated. Stridor, upper airway edema, you're going cool. Okay, now when we get into humidity, there's really two breakdowns that we need to talk about. The first one is the bubble humidifier. Now, when we think bubble humidifier, you need to think about nasal cannula. This is your patient who has 4, 5, 6 liters of oxygen running through a nasal cannula, and they're complaining of a lot of dryness. And that's because that gas that they're breathing is dry. So it's causing upper airway dryness. We can alleviate that with the use of a bubble humidifier. Okay, so nasal cannula, your patient's complaining about upper airway dryness, think bubble humidifier. Again, hook one up. Look at the nasal cannula. Can you see the humidification coming out of it? Absolutely not, because humidity is not visible. Okay, now when we get into mechanical ventilation, we're typically talking about passover humidifiers. And this is where our circuit comes from the vent. The gas comes from the vent and is actually going to pass over a heater that has water in it, right? We typically use sterile water in that heater, and the gas that passes over that water is going to pick up heat and humidity as it passes over that level of sterile water. Okay, now this breaks down into a couple of different ones. Now the regular passover just looks like a heater. Let me see if I can draw this. And you have a water level in here. This comes from the vent, the water passes over and then goes to the patient. As it passes over in this region, it's picking up that humidity. Okay, now there's another type of passover that provides even more humidity. So if you want to maximize humidity, let's say you're taking your TMC exam and it says which of the following will maximize humidity delivered to your patient, then this device called the wick is another type of passover humidifier. But what it does is it looks like this. I'm going to simplify this drawing. Okay, so you got this water level in here, and then you got these wicks that are sitting down. Maybe it's just one, maybe it's 3, maybe it's whatever, but they're sitting down in the water and they are drawing up the water, and they're this moisturized material. So that as opposed to just the passover where it just passes over the top and then goes to the patient and picks up the moisture here, this gas comes in and it surrounds itself and moves throughout these wicks before it goes to the patient, which allows it to pick up more humidity, which delivers a greater level of humidity to your patient. Okay, so that's the wick. If you're these are these questions that you just hate when you get to them on your TMC exam, because you go, holy crap, I forgot all about the wick and I don't know how it's any better than just the basic passover. Well, the answer is it delivers better humidity to your patient. Patient with super thick secretions, a wick passover humidifier will work better than a standard passover humidifier. Okay, the last thing we need to talk about here is, and again, there's more that we're not covering. I'm just kind of hitting the highlights here because this is already approaching 30 minutes. And if I hit any more than the highlights, I could take this probably on for an hour. You're talking about aerosol and humidity, which is 1 to 2 hours of lecture time in the classroom. Now, the last thing we need to talk about is the HME. This is the heat moisture exchanger. This is an artificial nose. So I just told you a little bit ago, we breathe in, we take in dry gas, it passes through our nasopharynx, through our nose, then we exhale, and when we exhale in our nasopharynx, we capture this heat and this humidity from that spontaneous breath. You see, when we inhale, gas is warmed as it reaches our alveoli. As we exhale warmer gas than what we inhaled. We also exhale humidified gas. It gets captured in our nose and in our nasopharynx, and the next breath we take then picks up that heat and that humidity for delivery to our alveoli to maximize mucociliary clearance and things like that. Now, when we talk about an HME, we're talking about a patient with a bypassed upper airway. So we're talking about a mechanically ventilated endotracheal tube, nasotracheal tube, or a tracheostomy tube. The research on this is kind of unclear because you kind of see where outcomes are similar to that of a passover. So you've seen a lot of facilities get rid of passovers and just go with disposable circuits, non-heated circuits with an HME. But the key is that anytime you're using an HME, it should typically be used for short-term mechanical ventilation. If your patient has an extended time on a mechanical ventilator or has very, 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 very thick secretions, then an HME is not going to be the best mode of humidification for that patient. You're going to want to switch to a passover humidifier. Okay, but for your short-term, your heart patients that come out of bypass, HMEs work wonderful. They save money for the hospital because you're using non-heated circuits instead of heated circuits. And you're providing a good level of heat and humidity for your patient. Now, this works the same way as our nose. The gas goes into the patient, it passes over the HME, dry and cool. But when the patient exhales, the heat and the humidity from the patient is captured in the HME. When that gas is captured in the heat moisture exchanger, the next breath comes in and it picks up that heat and that moisture, and it is then delivered to the alveoli where maximum heat and humidification is desirable. All of this stuff works together to promote optimal mucociliary clearance. Look, you can go on YouTube, you can go on the internet, look at research, you can do whatever you want to. What you will find is that mucociliary clearance, the beating of the cilia that moves out secretions in our patients and in us, me and you right now, it goes down as humidity goes down, and it decreases with cooler gases. So the warmer the gas and the more humidified the gas, the better the function of the cilia, which equates to better functioning mucociliary clearance. Okay? So HME, think short term. So let's say you have a patient on a passover and you got to go to CAT scan. You should probably put this patient on an HME during that trip. Okay, this is a short-term option to provide heat and humidity to your patient on a mechanical ventilator. Remember, if you ever have super thick secretions, you need to ask yourself, the HME is probably not the best option. Let's get this patient on a passover, on a heated circuit, and let's maximize mucociliary clearance. Now, the other thing you need to know about the HME before I wrap this up is simply this. If you have a circuit that's going to your patient, and you have an HME here, and then an endotracheal tube, and this endotracheal tube is going to your lungs. Okay? If you put a small volume nebulizer here on the inspiratory limb, this is inspiratory, this is expiratory, you need to understand that you need to take this HME out of the inline. You need to take it out so that all this medication doesn't get trapped in that HME. The better option is to put the HME distal to, put the SVN or the aerosolized medication distal to the HME. Because if it's proximal, if it's before the HME, then all of that gas is going to be trapped. All of that aerosol, that drug aerosol, is going to be trapped in the HME, and it's never going to reach your patient. Now, there's a few marketed HMEs where you can switch it. You can turn it from HME to aerosol status, and that's great. Just be sure to switch it. But with that, you have to remember when the treatment is over, switch it back. Put it back on HME, because if you leave it on aerosol, then at the end of that treatment, there's no heat and humidification happening for your patient. So you got to take the HME either out of the circuit, you got to put the medication distal to the HME, or if you're using one of those devices where you can switch it from aerosol to HME, to heat and humidity versus aerosol, then just be sure to switch it back when you're done. Okay, because if you don't, you're not gonna be optimizing heat and humidity to your patient. Okay, so this is a quick breakdown over the macro level of aerosol devices that deliver medication, aerosol devices that deliver bland aerosol, and humidity devices that will help to improve humidity based off of nasal cannula device versus also HMEs and your Passover devices, including your wicks. Hey, Tay, I hope this helps. I hope it answers your questions. For everybody watching, I appreciate it so much. Do me a favor right now. If you haven't already, hit the subscribe button and turn the bell notifications on. Here's the worst that's going to happen. You're going to be notified when I upload a video. If you watch the videos and you don't like them, unsubscribe. Turn the bell off. But if I'm bringing you value and I'm helping you along your journey to become a respiratory therapist or to become a better respiratory therapist, then stay in touch with me. And as always, send your questions down below. I will respond and answer them as quickly as possible. Okay? Best wishes, guys.